Singaradivil is speaking.
Oh, yes. Yeah.
Hello, sir.
Hello, Sundar.
Back in action.
Back to work. Work I mean, at home, but I'm just relaxing. I'm not doing anything. Great.
Oh, no. We have hospital polian, sir?
2 weeks. Like 14th day.
Oh, 1 week, no 1 week, sir.
Another 1 week.
Oh.
சுந்தர்ராஜ் எப்படி இருக்கீங்க?
நல்லா இருக்கீங்களா சார்? நல்லா இருக்கீங்க சார். அது நிறைய நாள் எங்களுக்கு சிஓஎஸ் மீட்டிங் எங்களுக்கு இந்த ஆர்த்ரோஸ்கோபி சொசைட்டி மீட்டிங் கிளாஸ் ஆயிருக்கு சார். ஃப்ரைடே சாட்டர்டே. அதனால 2-3 மாசம் ஜாயின் பண்ண முடியல. ஹாய் ஸ்வர்ணகுமார். சிங்கார் வடிவேல் எப்படி இருக்கீங்க? சிங்கார் வடிவேல் மியூட் பண்ணிருக்காரு.
அவரு சேலம் மீட்டிங்ல இருக்காரு.
ஓ சரிங்க சார். ஓகே. அவரு
சார் கேக்குதா சார்?
சிங்கார் வடிவேல் நீங்க என்ன வேர்ல்ட் டூர் மாதிரி தமிழ்நாடு டூர் போயிட்டு இருக்கீங்களாமா?
ஐயோ ஏங்க நீங்க வேற என்ன பண்ணிட்டு இருக்கீங்க? ரெண்டு ஒரே சமயத்துல கரெக்ட்டா வந்து ஆமா.
சார் தேங்க்ஸ்.
குட் ஈவினிங் thank you. சார் குட் ஈவினிங் சார். திருமலை சார்.
சிங்ஸ் எப்படி இருக்கீங்க?
நல்லா இருக்கு சார். எப்படி சார் இருக்கீங்க?
I'm fine, thanks.
ஹலோ சார். ஹலோ சார். குட் ஈவினிங் பாலா சார்.
சேலம் மீட்டிங் முடிச்சிட்டீங்களா?
இல்ல சார் இது முடிஞ்சதா சார்? 7:30க்கு அங்க வரேன்னு சொல்லிருக்கேன். இத ஃபர்ஸ்ட் முடிச்சிட்டு அதுக்கப்புறம் போலாம்.
சரி.
எஸ் சார்.
அது ஸ்டார்ட்ஸ் அட் 7:30ங்களா?
இல்ல சார் 7 தான் சார். அது சார் நான் ஃபர்ஸ்ட் இத முடிச்சிட்டு ஃபர்ஸ்ட் டாபிக் இருக்குறதுனால அத கொஞ்சம் வேற ஏதாவது டாபிக் பேசுறேன்னு சொல்லிட்டு. சரி ஃபீட்பேக். எஸ் சார்.
தனசேகர் இவர் இருக்காரு. ஸ்வர்ணகுமார் ஸ்ரீலங்கன் ஆர்த்தோபெடிக் அசோசியேஷன் பிரசிடென்ட்.
அப்படியா? Oh, I didn't notice.
Hi, Sundar.
Swarnakumar, how are you?
I am fine. How are you doing?
Good to see you again within a week.
Yeah, within a week we see you again.
I think Owen doesn't know Swarnakumar is the Sri Lankan Orthopedic Association president.
Oh, it was welcome to our meeting, sir.
Thank you. Nice to meet you all.
Good to see you.
And I was in APSS meeting today.
Okay.
And Dr. Rajasakaram was there, Prof.
Oh, he told you. Okay, you meet Dr. Thirumalai Sami. He is the Tamil Nadu Orthopedic Association president.
Hello. Namaskaram.
Namaskar. Right. So how are you doing? Yeah.
So how is the situation in Sri Lanka? COVID?
Yeah, Sri Lanka COVID, we were doing well. Nowadays, we are getting so many positive patients, but serious cases are not much. Actually, we had only about 13 deaths until now.
So, good evening, everybody. Welcome you all for the Coimbatore Orthopedic Society monthly meeting. I welcome our President TNOA, Dr. Thirumalai Sami, our COS President. I had to mute, I think.
You're audible.
One second. Today, we have a guest speaker for our Coimbatore Orthopedic Society meeting, Professor Singar Vadivelu, professor at Madras Medical College. He's going to join us and is going to give a talk on management of giant cell tumor. I request Dr. Balasubramaniam to share a few words before we start the meeting.
Good evening all. I welcome my good old friend Singar Vadivelu. I know him more than 30 years. In fact, he's 1 year senior to me, but he looks much younger than me. Fortunately or unfortunately, he went to Chennai and settled there. And he's doing very well. I'm proud of him. And I welcome Singi. Hi, Singi.
Hi, hello, sir.
Welcome to Coimbatore virtually.
Thank you.
And I also welcome our TNI President Tirumala Sami and the Sri Lankan orthopedic surgeon. Sorry, I forgot his name. I welcome you, sir. Swarna Kumar. Yeah, so, Swarna Kumar, sir, please welcome. And I welcome all our members. And if there is any guest members, I also welcome you all. And I hope you'll have a nice time. And Singi will enlighten us with the newer techniques in giant cell tumor management. Welcome you all. Singi.
Thank you, sir. So, shall I start sharing?
Yes, sir. Please.
Yeah. So, good evening to you all. Respected President of the Coimbatore Orthopedic Society, Dr. Balasubramanian, Secretary, Dr. Dhanshekar Raja, and the President of our parent body, Tamil Nadu Orthopedic Association, Dr. Tirumala Sami, and the international faculty, Dr. Swarna Kumar, and all the rest of the members of the Coimbatore Orthopedic Society. At the outset, I wish to thank the Coimbatore Orthopedic Society profusely, my alma mater, Coimbatore. I always have, and nothing can equate being in Coimbatore. I would have loved to be there and then give the real talk, but unfortunately, due to all these times, difficult times, that it is a virtual talk. And still, I would love to be associated with Coimbatore people. So, with those few words, I thank once again for the opportunity given to me. And I'm going to talk about giant cell tumor, the challenges in joint preservation. So, that is the biggest challenge I think we have in the management of giant cell tumor. So, greetings from the institution where I'm working now, the Madras Medical College. And before I talk anything about orthopedics or in giant cell tumor, I wish to thank my professor, my guru, I would say, in so many aspects, Dr. Paul Ayakuti, so with whom I have been associated for more than 25 years. And he has done a lot of work in giant cell tumor. The main interest I developed, and a few slides of I've got it from him, the work he has done. And with the due regards and respects to Dr. Paul Ayakuti, I'd just like to start talking. It was in 1818 Sir Ashley Cooper who described giant cell tumor, and its local aggression has been highlighted by Melton. So we all know that it affects the ends of the bone, and most often it affects around the knee joint, the bones around the knee joint, the distal femur and proximal tibia. So this slide, it is very important. We see the few characteristics that the cartilage is a good barrier. It never penetrates, but it is almost so close to the cartilage, which affects the joint surface. And if you see carefully, there are a lot of septae, and the tumor almost extends beyond what we see macroscopically. So these septae in which the tumor tissues reside safely. And in this, if you see that the tumor is confined, though it is ballooned out, there is a fibrous capsule which confines the tumor within the bone. And if we see the cortical bone, which is supposed to connect, it's almost completely destroyed. So the distal end of the femur, it is telescoped inside, losing the structural stability. So once the tumor is removed, there is no structural stability here. So this is what we have to understand. And if there is any metastasis which is locally aggressive, it can be a solitary nodule in the lung, which can be removed, excised, and clearance can be good. So what do you do when we see a giant cell tumor? You take an X-ray, the CT and MRI at the local part to find out the extension, X-ray chest and CT chest to find out if there is anything in the chest. And of course, however clear it is, we'll have to do a biopsy before we go on to the treatment. So the challenges actually we face when we are treating a giant cell tumor, it is the young age, in the second and third decade, the patients are involved, and it is proximity to the joint. This joint function is very, very important, and the function as far as possible we'll have to do. And recurrence is the issue. Locally, we can treat, we can assume that we have cleared the tumor, but the propensity for the recurrence, it is very, very problematic. So we'll have to prevent the recurrence also. So we know that when the curettage is done, the recurrence is more than 50%. And with various modalities, bone grafting has up to 20 to 35. With cement, it is 15 to 20. With adjuvants, when we use, it is reduced to 5 to 10. The best result is, of course, the wide resection of less than 5%. So when it is within an expandable bone, like an upper end of fibula or lower end of ulna, these are the bones which can be resected, and we can see however much we can give a clearance, and still we can have a disease-free and we can preserve the joint. But if it is involving the lower end of femur, so what do we do normally? We have to make an adequate window for a successful treatment. The window, there should not be anything which is beyond this area. So the window should be adequate so that we see the corners, everything very clearly. And then we have to use a high-speed burr, not the normal burr what we use, a high-speed dental burr, which opens all the crevices so that all the tumor tissue, because that is one intervention which reduces the recurrence rate. So that is very, very important. An appropriate adjuvant is very important. And then how do we fill this cavity? So that filler, of course, it decides. So what are the challenges in this managing this kind of tumor? A large void is left behind. There is only a thin wafer of subchondral bone. Though it is not penetrated, it is only cartilage essentially, and there is no bone almost. And how to prevent the collapse of this cavity? So it is a fine balance between adequate clearance and how to maintain the normal bone. After the local adjuvant use, which we call it as an extended curettage, we can use a liquid nitrogen, phenol, or absolute alcohol. We have been using liquid nitrogen quite frequently earlier days. So we open, then we put, it is almost like a movie effect, a cinema effect you can have. So there will be a smoke so much, and we have to protect adequately with hot saline soaked pads all around the skin so that this cold temperature doesn't affect the thermal necrosis. Cold necrosis doesn't cause, and it results. However much you protect it, there may be some thermal injury, thermal burns, and this is how the results. But can we do the same method everywhere? So if there is a tumor like this, if you take a CT, almost there is a breach in the cortex posterior. So if there is so much of necrosis which can happen for the skin, what happens if the liquid nitrogen goes just behind this? So in this area, the vital popliteal artery and the neurovascular structure which is there, if it goes and if it causes some damage, the entire limb viability becomes a problem. So what can we do for that? So liquid nitrogen causes thermal injury. Is there any alternative? So it has been proved that hydrogen peroxide is as good as liquid nitrogen, or for that matter, any adjuvant. Even a distilled water is as good as that, because the Canadian meta-analysis which says that whatever be the adjuvant, the most important factor in determining whether it's going to recur or not is only the adequacy of the curettage, the high-speed burr and everything. So this we can use. So we started using hydrogen peroxide, 3 washes, and then so hydrogen peroxide was used, and then how to fill the cavity. So what are the methods with which you can use? So bone graft was tried. So the bone graft, there is a slight increase in the recurrence rate, and how much time does it take for it to incorporate and become structurally stable so that the patient can stand and walk, because it is a huge cavity what we leave behind, and the time delay for the rehabilitation. So we started using bone cement. So the bone cement, does it have an adjuvant activity? The thermal necrosis for it, it meets 60 degree and it almost reaches only 1 to 2 millimeters. So that may not be very adequate to call it as an adjuvant, but whatever it is worth, because it reaches only around 37 degrees, which may not be adequate, but for whatever it is, there is an adjuvant activity. It provides immediate stability. So that immediately, because it is not going to depend upon the bone remodeling, immediately the patient can be made to stand and walk. And the recurrence, if at all, if it happens, it is easy to find out, because of the sclerosis here, if there is any lucency which starts developing new, then we'll know that it is recurring. So this is a patient. There is a posterior cortex and the lateral cortex is almost devoid. So what are we going to do? Are we going to use a bone cement? So the problems are, we will have to think in terms of a column concept, because in the orthopedics, almost in trauma, everywhere it is a column concept. So if you see the acetabulum, this is the anterior column, posterior column. We divide it to stabilize it. How to find stability of the bone. So if it is tibia, it is the medial column, lateral column, the posterior column. So by which we try to find the stability. So which column is disrupted, we will have to. So in this way, same way, we can see the lateral cortex is gone. There is something in the medial cortex and the posterior side. So what can we do? The problem with the bone cement are, it is an inert material, so it is not going to remodel. Whatever we do, something has to remodel. The Wolff's law should act, and then there should be some remodeling which should happen. If it doesn't happen, then it can be a stress riser and it can fracture. So we will have to address that issue also. And also, secondly, the articular cartilage. It is almost going into the cartilage. If bone cement, which is a hard surface, which goes just beneath the cartilage, which is little pliable, so that sudden change in the stress, it is going to affect the cartilage. It is going to cause an osteoarthritis. So what are the ways in which you can do? So one is a thorough curettage, as we already discussed. So the increased stiffness of the bone cement is going to lead on to the degeneration, and also it can cause thermal necrosis to the cartilage. So that can be prevented by a sandwich technique, which we all know. A cancellous bone or a bone substitute, it can be laid just above the cartilage, so that will prevent the sudden stress transfer from the cartilage to the bone cement. And the column which is deficient, if you just fill it with cement, it is only the medial cortex. Laterally, it is only the cement. Anytime it can just fracture in the supracondylar region. So if you just put in the bone here and then fill it up with cement, so what can happen is, so the bone was kept and then the cement. We all know, even in the presence of the bone cement, the bone gets united and then it remodels. So heals with additional fibular strut with bone cement, external support, range of movement after 6 weeks, weight bearing after full consolidation. So this was the immediate post-operative. And you can see in 7 months, the fibula, whatever which you have laid, is incorporated even in presence of the bone cement. And then you have a column support as well as immediate stability with bone cement. And then you get the sandwich technique and cartilage is supported, and you have preserved the joint. What happens if there is a recurrence? This is 2 years post-op, as I was mentioning. There is lucency which is happening. So there is the tibial tuberosity attachment, patellar tendon, which is very important for the knee joint. Still, what we can do is remove the bone cement. We need not be very aggressive, suddenly jump into a resection. Still, we can do the same thing, adequately again curate, adequately give again an adjuvant, fix the bone tibial tuberosity to the bone cement, and then you can do it. Still preserve. Because as long as there is no fungation, still there is a possibility that the joint can be preserved and the patient can have the patient's own bone. Now comes the problem. So if there is a gross destruction of the entire lower femur, what are we to do? Is there any way in which you can salvage? So this is the point where it comes. So what is the option? So can we do a custom mega prosthesis? We just resect and put a tumor prosthesis inside. Should we do an arthrodesis and get the knee, knock off the knee joint? Or should we attempt still a joint reconstruction? So custom mega prosthesis is a very excellent, immediately satisfying, gratifying procedure. But what happens if you do a custom prosthesis? You'll have to always think it is a fully constrained joint, and for such a big prosthesis, a very short stem. So this is going to take the brunt of the stress, whatever is going to happen, because of the highly constrained construct. So in 3 years post-operative, so this is going to start moving inside. So with such a big lever arm, it is going to move. One thing what we must remember is the life of the giant cell tumor affected patient is not going to be affected because it is a locally aggressive tumor. So the patient, when they are affected in the second or third decade, if you do a prosthesis, if it fails in a fully constrained, whatever the best implant, even if you put, it is going to last for 10 years or 15 years in the best of the hands. So what is going to be the management protocol if the patient comes to you with a loosened implant? So there are so many instances. For such a long implant, you are going to have such a small fixation. This is going to loosen here. Immediately, you may have a good result. But what is going to happen on the long term? So any orthopedic intervention, if you are going to do, so we have to understand the biomechanics, how much the implant is going to survive, how many years. So if it is going to, what is the life of the patient? So if it is going to fail, what is the revision option I have? So a role of CMP, it is young patient, again, a constrained joint with a long lever arm, near normal lifestyle. Early failure with the resultant huge defect. Whatever the initial defect was, it is going to increase. Then we will not have much of an option at that time to address that. And it is very difficult to revise. So it is not recommended, or it has a very rare indication, like all the planets lying in the same line. It has got a very, very rare indication. So what are the other options? Can we do a resection arthrodesis? It is a good lifelong solution, but the patient will have to loosen it. So you can either use a plate, or you can use a fibular graft and a nail combined, and then you can try to fuse it. So these were the initial X-rays, as I was telling by my professor. And this is also one of his X-rays. So this is a very excellent procedure. A lateral condyle is involved, and they're reconstructed with Petala's transposition and fixing it with screws and iliac crest grafts. And this is 11 years post-operative. This is consolidated very well. So this can be used for a medial or lateral femoral or a tibial condyle. This is an excellent procedure, the Marley-Deoband procedure, with a very good function. But are we bestowed with such a great skill, and do we have so much of bone and only one condyle is affected? So what are the issues in preserving the bone and joint? Clearance, adjuvant. Is there a role of systemic adjuvant? If there is something like a systemic adjuvant and which prevents a recurrence, that will be really wonderful. How to protect the cartilage? What is the method to fill the cavity? How to ensure the bone heals? And what is the literature support? Now, there are two systemic adjuvants, zoledronic acid and denosumab. Denosumab, which was little costly, and the institution where I work, it is little difficult. So I have some experience with zoledronic acid. It is a second generation bisphosphonate, acts by promoting the apoptosis of the stromal cells, which are the main malignant component of the giant cell. So this is administered, of course, with a normal glomerular filtration rate and a creatinine clearance. So the recurrence rate is, there are a lot of studies which says that it has reduced significantly, the recurrence, when it is used as a systemic adjuvant. So what does that we did, the study? What we did was curated the cavity and the standard guideline, and we left the cavity because we thought that the bone graft, whatever it is, allograft or an autograft it is difficult to get. An autograft also increases the chance for recurrence. And we also know that based on our trauma experience, that all the cavities need not be filled. So it is only the column which needs support. If the column is supported adequately, this space, if it is left empty also, this can get filled up. So the cavity was left empty, and fibular cortical struts were used to support the cavity. So this is what we do. So zoledronic was used as a systemic adjuvant. It was used 3 weeks preoperatively. Hydrogen peroxide was the local adjuvant. So the cavity left behind following the curettage fills up with blood and clots, and eventually they ossify. So there is adequate evidence. So what we did was the biopsy was done, proven with giant cell tumor, preoperative dose of zoledronic acid. Surgery was done 3 weeks later. Total of 3 doses of zoledronic acid. One before surgery, second 3 weeks after surgery, and the third 6 weeks after surgery. So these are 3 doses, because in literature it is not clear. Some were giving 3 doses, some 5, some 6. There is no consensus actually. We started giving it with 3 doses of zoledronic acid, and we had a wonderful result. So this is the flowchart what we did. So this is how we did. So the cavity was curated, hydrogen peroxide was used, fibular strut. So in femur, what we did was superior to inferior we measured, and medial-lateral to protect the articular surface. And if there is a posterior also, if there is not much of a support, anteroposterior also, we used the strut. So this is how we place the strut. So we did this, and this is 2 years post-operative, and this is the post-operative. So there is not much of a subchondral collapse, and the cavity is getting filled up, and the fibula unites very well. So this is another case. Tibia, we don't do anteroposterior. It is only mediolateral and supro-inferior. So nothing, no implant we use. Very rarely we use an implant. Only the support what we get on the table. And if it is not moving, there is not going to be any movement happening, because we are going to protect with the plaster of Paris. And this is 2 years post-operative. And this is the post-operative picture. And this one was very interesting. AP, unfortunately, I don't have. The medial column, lateral column was not there. The medial lateral, there was nothing. So it looked like almost we just dropped the fibula inside. So the medial, superior to inferior on the medial side, lateral side, and the medial lateral. So this much amount of fibula only was available. Just we kept our fingers crossed, but this is how it consolidated. So the supra-inferior medially and laterally, and also the subchondral support what it gave. So joint surface is maintained, though the range of movement is less. But for whatever it was, because she was referred from Dharmapuri, and everyone were offering only custom prosthesis, and one of my postgraduate referred this patient to me, and this was done, and this patient is having her own bone with this much of range of movement. So this is another, and this is 2 years post-operative. And there was one distal tibia also I treated with the same method. So this much of collapse, almost the lateral aspect, the tibia is not there, and anteriorly also was not there. And this is 15 weeks post-operative, a nice consolidation, and the cartilage which is being maintained. Then we started measuring the tumor volume. Does it have anything to do with the time to take for consolidation and for the patient to bear weight? So we measured in CT anteroposterior mediolateral. The mass, the volume was calculated. So 11 patients we did, 2 of recurrence and 9 of primary, 5 distal femur and 6 proximal tibia. The tumor volume was, the average volume was 92 cubic centimeters. This is around 4 above and 7 below. So this is the appearance of callus. So in 8 to 16 weeks, the callus appeared, and the low tumor volume, 2 cases there has 1 infection, 4 complaints. Otherwise, everything, when the volume was less, it is within less than 16 weeks. More, it is almost around 20 weeks it took. So the average was 18 weeks. We can see some of the cases. So this is 28 with GCT, distal femur. So this is how it was reconstructed. So, anteroposterior, mediolateral, and supra-inferior. And this is 16 weeks. 16 weeks, the consolidation is so much without filling anything in the cavity. So this is 2.5 years follow-up. So this is a recurrent tumor, similarly done, curetted and the fibular strut. This is 1 year post-operative, consolidation taking place. So this is the patient walking, almost a near normal walk. And this is 2 years post-op, 2 years follow-up. This is the range of movement the patient is having. So what is that? How much of consolidation is taking place? So extended curettage, bone grafting, external fixation, reconstruction with a non-vascularized fibular graft, 31 patients. There was almost 6 months to take. So this 30 patients, 6 months it took. So for us, it took only 4.5 months. So probably this earlier consolidation was because of using zoledronic acid. In our arthroplasty experience also, when we use allograft, we always follow it up with the zoledronic acid. That zoledronic acid, it consolidates whatever graft we put so fast. So probably the zoledronic acid is doing the trick, and it provides us early consolidation. So the take-home message will be a thorough curettage. There is nothing to replace that. And a high-speed burr, if there is any cancellous bone, it has to be curated thoroughly. That is the one which is going to prevent the recurrence. An adjuvant must be used, suitable adjuvant. Hydrogen peroxide is as good as anything else. There is no need for filling the cavity, like a locking plate, no need to fill the cavity. Just if subchondral support is given, that will prevent the collapse of the cavity. A fibular strut is to perform that function, and it is to protect the column. So you think the bones as columns, and what are the columns which needs to be protected? So if that column is protected adequately, it consolidates very well. The addition of zoledronic acid, according to our experience, though it is very small, around 11 cases with more than 2 years of follow-up, none of them have recurred, and zoledronic acid really provides a good systemic adjuvant. So to conclude, that this is the first slide which I did when I was a postgraduate. Still, I feel that it holds good. The treatment of GCT leaves much to be desired. The analysis of several large series have appeared in literature. Some only add to the confusion of the reader when he attempts to determine the proper course of treatment for any given GCT. So it is for us to choose, but I feel that this addition of zoledronic acid, fibular strut to protect the column, and adequate curettage at present the best way for managing the giant cell tumor and to preserve the joint. I once again thank Dhansekhar Raja and the entire office bearers of the Coimbatore Orthopedic Society for having provided me this opportunity. Thank you once again.
Thank you, Dr. Singar, for the excellent lecture on management of giant cell tumor. We can ask the questions now. Request members to. Yes, sir.
Yes, sir.
Along with the strut graft,
Yes, sir.
I think putting some cancellous graft accelerates the union.
Sir, that is what I said, sir. 2 things I want to, because there are literature which says that addition of cancellous graft, there is a slight increase in the recurrence rate. So we cannot say why it is happening, number one. Second is amount of consolidation which is taking place, whether we put cancellous graft or not, because the other two studies which he quoted, which had 6 months for the consolidation take place and the patient to walk. In our cases, on average, all the tumor volume considered, that the consolidation was taking place in 4 to 4.5 months. Partial weight bearing was happening in 3 months on an average. We only put the POP for 6 weeks to maximum 10 weeks. And then we start moving. They get the joint function as well as they are able to move.
Okay.
Yes, that's Sundaraj.
There is no need
Sir,
for.
Yes, sir. That's what I feel.
Sir, in the same vein,
Yes.
suppose if the weight-bearing articular surface doesn't have a good quality bone, I mean, did you add cancellous stripes or the subchondral area and put the fibula graft, or you put directly that fibula strut graft? Will it hold?
No, it was only directly. Even, yeah. So understand, I had the concerns how much the cartilage is going to collapse. But even though when I just palpated, the cartilage was little pliable and there was no absolutely subchondral bone support, I just kept the fibular graft and I wanted to find out what is the recurrence rate if the cancellous bone is not kept. Because one of the surgical oncologists was telling that cortical bone doesn't produce recurrence, but it is only anecdotal and there is no literature support for it. There are few literature which says that adding graft increases the recurrence, but actually there is no exact literature support. So I didn't want to put any cancellous graft, but it was able to protect the articular surface.
Okay.
So when will you allow to weight bear, Dr.
Sir, that is what, sir. The maximum is 12 to 16 weeks when I start allowing them, removing the POP and then allowing them for mobilization, partial weight bearing based on the appearance of the callus. It starts in 12 to 20 weeks. Then I allow them to bear.
So probably if you use cancellous bone, autograft, it undergoes early revascularization and promotes the growth of the residual tumor if at all we leave behind. If you use only allograft or structural graft, the chance of tumor proliferation is avoided.
Correct. That is what the thinking is, but we don't have a literature support. But probably that is the reason why there is slight increase in recurrence if there is a cancellous graft which is added.
Second thing, with zoledronic acid, you give pre-op, is it 3 doses? Or?
Yeah, 3 weeks before. Actually, I find that the tumor becomes little more solid. Because the routine giant cell tumor, when we cure it, it is most friable. But we use that zoledronic acid, it becomes little firm and it comes like cakes, and the curettage is little better. Yeah, so we could see, and we also studied the histopathological appearance. Almost 100% of the cases, the necrosis they were able to find. So they were not able to find any viable cells when zoledronic acid was given.
The same. The same thing happens when we give denosumab.
Good evening.
Yeah.
If you use denosumab, we found the same type of reaction. It inhibits the osteoclast and allows
so that makes
consolidation of the tumor and helps in removal of the tumor.
Correct.
We have better clearance.
Correct.
But the only thing is we need to go one layer beyond the capsule, pseudo capsule, to make sure that the tumor cells are not getting incorporated with the shell.
Yeah, that's correct. Yes, Dr. Devendra, you want to ask?
Yes. Your results with the fibula grafting looks fantastic, sir. Just wanted to know, instead of using autograft, can we use only allograft, sir? Because you are using 3 fibula.
Yeah.
Only
so it can be done.
It can be done. But
it can be done. Yeah.
What do you think is the recurrence rate or healing chances, sir, with only allograft?
Hello.
With the allograft, what we have done, our experience is only with the arthroplasties, not really with giant cell tumor. But the consolidation, I feel that it has got more to do with the zoledronic acid. So once you give, the consolidation take place just like that. So as for autograft, the allograft also should get incorporated. We see. So I feel that it should happen, but we don't have the facility for harvesting the fibular graft. So cadaveric graft, once it becomes big, so fibula probably will get more and we can have more of column support.
One more question, sir. Regarding recurrent lesions, when do you decide to go for one more surgery by curettage and salvaging the distal femur or proximal tibia instead of choosing arthroplasty?
Sir, I almost never do an arthroplasty. So for even if it is a recurrence, if it is not fungating or if it is not come out extra compartmental, a huge soft tissue component which is gone extra compartmental, which we think that we will not be able to provide adequate clearance. Because always, as Dhansekhar was telling, that there is a pseudocapsule, the fibrocapsule is there. So we'll be able to excise that. And it is almost only a local recurrence. We have not seen one like that. I was discussing with some onco-orthopedic surgeons, and they were telling that once or twice in a year, 1 or 2 cases only, those high-volume centers also, they have an opportunity to do a resection and custom processes. Most of the time, they are able to do only with, even if it is recurrent, second or third recurrence also, try to preserve the natural bone.
So in your series, how many patients have recurrence, sir?
No, in this, after the tubular strut and zoledronic acid, that's what I have not had. 2 years is a reasonable period for a giant cell tumor because more than 90% recurs within 2 years. So, but still, we need really a long term to say meaningful conclusion with larger number of patients. But as of now, with zoledronic and the tubular strut, I have not had recurrence. Now it is almost 15 patients. 11 is the one which we studied. It is almost 15 patients, but we have not had recurrence.
You said 3 doses of zoledronic acid you use.
Yes, sir.
What's the dose you use usually?
The normal, whatever which we give for the 4 milligram.
4 milligram, 3 doses.
Yeah.
What's the interval? What's the interval?
6 weeks.
What's the
6 weeks. Preoperatively, 3 weeks pre-op, 3 weeks post-op I give, and then next dose is 6 weeks later. So interval between zoledronic acid is 6 weeks.
Okay. Thank you.
Any role for teriparatide?
Teriparatide in tumor condition we should not give, sir, because any tumorous condition the teriparatide must not be given. I don't think there is any role of teriparatide because it can cause problem.
Okay.
I have
yes, sir.
Comment to make.
Have you seen any metastasis, Singhi?
No, sir, I have not seen. It is reported in literature, but I have not seen.
Yeah, not seen, huh? Okay.
Not seen. Yes, sir.
When you have recurrence, one has to be careful, and you may miss some osteosarcs, which presents as giant cell tumor. We have come across few.
Okay.
King Faisal Specialist Hospital and Research Center when I was working there, and some of the giant cell tumors, so-called giant cell tumors, were reported by giant cell variant of osteosarc. This is by Dr. Unnikrishnan from Mayo Clinic.
Yes, sir.
So when you have a recurrence, you have to be doubly careful before you decide in line of action.
Yeah, that's true, sir. So how the aggressive is the recurrence, and we take a biopsy, even if it is a recurrence, even if it is MRI proof, we take a biopsy and then only go to salvaging the joint. Yeah. We keep that in mind, but we have not had the osteosarcs presenting it as a recurrent giant.
I think I can remember at least 3 or 4.
Oh. Yes, sir. High volume centers probably.
Yeah, since there was about 40 pathologists, and they are all there was no consensus with the confirmation. So we have to ask Unnikrishnan to finally give the verdict, and he changed the label as his giant cell variant of osteosarc.
Oh,
that ended up in the resection afterwards.
Okay. So that is information.
With that note, we had a similar patient which has reported a giant cell tumor 10 years back, curettage and completely healed. After 10 years, patient had a recurrence. And biopsy done also came as giant cell tumor. But when we resected the tumor and sent it for the entire tumor for biopsy, it came as an osteosarc.
Osteosarc, okay.
Sometimes it can happen. Also, I had a recurrence. We had a recurrence 4 years after curettage and joint preservation after GCT. So this week only I sent a repeat biopsy, multiple biopsy samples we have sent. So,
since I have a question.
Yes, sir.
We have treated some of the patients with curettage, this cryotherapy, burr excision, as well as cement filling and plate fixation for proximal tibia.
Yes, sir.
It's almost 6 to 8 years follow-up. They are all young adults.
Yes.
So I'm just wondering whether just to leave it like that, or should we call them and remove the plate and put the fibula graft to make sure the natural bone heals? What would be the ideal thing?
Yes, sir. So actually speaking, if there is no recurrence and the patient is doing well, ideal will be to remove that and put in graft, sir, so that the natural stresses it passes and the bone gets remodeled. Because we do not know after some time how the bone is going to. But it is very difficult to convince, and I think it may be difficult. Yes, sir. To tell the patient that everything is all right, but still we have to do a procedure.
Yeah.
Yes, sir.
No, I think it may not be necessary, sir, because we are having a cavity and we are de-roofing in one wall only. If you see the tibia, there is anterior wall, posterior wall, medial and lateral wall. We actually de-roof on one side, expose the entire tumor, and the joint we protect with allograft or something, and the remaining we pack with the bone cement. So we have three strong cortex to support the natural bone. I don't think it's necessary to go back and remove the cement.
If the patient is asymptomatic.
Yes, we also have follow-up up to 10 years and they're all doing well. So it depends on how much residual bone we leave behind.
Yeah.
If we are short of bone, then we need to use a graft like a fibula graft and reconstruct it and support it.
Support it.
Yeah. Otherwise, if three cortex are intact, that's good enough.
On the lateral side, if it is there, then probably the fibula is also there. As you said, medial, lateral, and everything is okay. But if it is on the medial side, I have my own doubt. If there is a significant medial cortex breach and we have gone through the medial aspect, so then there is a question.
So we
I have always an issue.
Yeah, we discussed with the surgeons from Tata Memorial.
Yeah.
They routinely use bone cement. So they are using for large cavities and they don't do anything else other than this, protecting the cartilage and bone cement. They have excellent results.
Yeah. Of course, it is time tested and approved.
Yes, sir.
Sir, when you have a GCT of the distal radius, if it recurs with only volar soft tissue component, do you think complete excision of the distal radius is better, or still we can try one more curettage and allograft packing of allografts?
And as far as distal radius is concerned, we must have a very low threshold for doing a fibular hemiarthroplasty. That's what we call removing the distal radius and putting it in a fibula, because it has got a very huge propensity for recurrence. And if it has already recurred, if you have done once a curettage and if it has recurred, I don't think there is any role for doing a repeat curettage. And the fibular replacement, it gives very excellent result, very useful wrist, and both dorsiflexion, volar flexion, as well as some amount of this movement the patients have. So I think that next time we have to do only a fibular reconstruction. Only thing is we will have to maintain that ulnar variance. The height of the fibula is the trick. So if the height of the fibula is right, then the result of fibula replacement is very good.
What about ulnar translocation and fusing ulnar to wrist, sir?
Yeah. So there is a huge series people have presented, but I will not say, because we have got a adequate number of cases with fibular reconstruction, which is almost like a near normal radius, and people were not able to find out whether it is radius or fibula. It almost mimics that, and you've got a reasonable function. So I would say that fibular reconstruction is little better functionally. Whatever you give, dissection, then followed by a fibular reconstruction gives this function also. So I think
that put the wires the distal, I mean, ulnar to fibula and then
fibula
carpal
and the carpus also. 6 weeks we have to maintain, remove it, and then start.
Okay, sir.
Yes.
Biopsy for a GCT for a diagnostic purpose, and then when you are going for a definitive treatment, do you excise the tract of the biopsy, or just you curate and do whatever or cementing whatever things you will try to be conservative surgeon?
We try to go the biopsy and whatever the definitive procedure what we are going to do, try to go in the same track, so that we'll be able to remove that biopsy site also.
Okay.
We try to do that. If it is core needle, that is what we normally do. The cortex is thin enough that we allow core needle. So it is easy to include it in the incision.
Okay. Thank you.
Dhansagar?
He needs to go to Salem, seems.
Yeah. I have to go to Salem.
It's 7:30.
Yes, sir.
Bala, sir.
Sir, I think unmute yourself,
Dhansagar?
sir. Dhansagar,
Yes.
sir. Unmute yourself, sir.
Oh, thank you
Yeah.
very much, Professor Singarodu, for the excellent lecture on giant cell tumor. Always giant cell tumor provokes a lot of interaction with all the surgeons, and it's an interesting topic. Thank you for sharing your excellent technique and long-term follow-up. So I was a student in when I was doing my special training in Kilpauk Medical College when he was assistant professor. So it is nice to have you back, sir. And he was also the secretary for the TNOA. Thank you for sharing your time and being with us. Thank you very much.
Thank you, Dr. Dhansagar, and thank you, the entire COS team. And thank you, sir. Bala, sir. Thank you, sir. Thank you, Tumors, sir. Thank you. Thanks for everyone. Thank you, Devendra, sir. Thank you, Suvarajan. Thanks. Thank you.
Thank you so
sir.
much. Thank you. Thank you.
Sir,
Bye.
thank you, sir. Thank you, Dr. Sir. Thank you.
So next, we'll have some case presentation. Anybody's presenting a case? Bala, sir, you're having a case, sir? Yes, please. Can you share your screen?
Yes. Okay, well, can you see?
Yes, sir. Please go ahead.
Right. Good evening again. Since the guest lecture was GCT, I thought of showing a couple of my cases. Okay. So when I was working in Ramakrishna, I had an opportunity to do some of tumor cases with that oncology guys. This is one of case we did in 2010. He's a 21-year-old college-going guy, came with pain, swelling of the right knee. Obviously, you can see there is a tumor with pathological fracture of the right lateral condyle femur. So this is what the MRI shows. It's almost, it's broke the cortex. The tumor has gone migrated everywhere, inside the joint as well as lateral side. And this is the CT. Very well you can see pathological fracture. The tumor has gone anterior, posterior, everywhere, and also into the joint. So, Dhansagar.
Yes, sir.
What do you think? What shall we do?
So it's a first time presentation.
Yeah.
So always once you confirm it is GCT, it's always good to attempt salvage of the joint.
Okay.
So we'll do a extended curettage.
Okay.
With the burr, and I use bone cement also to extend the curettage, and we protect the joint surface with the allograft. We pack the joint surface 2 to 3 mm allograft. We impact and try to protect it because bone cement releases a lot of thermal energy. So protect the cartilage, we use some allograft. And in this case, when the lateral column is not there, maybe I'll think of some structural graft or like a fibula or cement augmentation.
Okay. Why allograft? Why not autograft?
That's what because we have allograft, that is one thing.
Okay.
Then autograft adds to the morbidity of the patient. To pack this cavity, we need a lot of grafts.
Okay.
And allograft results are good, and it prevents tumor revascularization and tumor proliferation. That we discussed. We don't have a literature support, but I feel that can prevent repeat tumor recurrence also.
Okay. Okay. Right. I'll show what we did. This is what we opened. We can see the fracture through which the tumor particles are coming into the joint. And we open the cavity through that fracture and thoroughly curated with the burr also. And we did cryo with the liquid nitrogen. You can see the protection of the skin with this swab, and you can see this liquid nitrogen. You can see even the vapors are coming. And this is what the cavity after curettage, after cryo. This is how it looked like. We just packed with the bone graft, autograft, cancellous graft from the iliac crest, and fixed with a locking plate. And this is the post-op X-ray immediately. Any comments, Dhanshagar?
Yes, sir.
Okay.
So it looks good. That's looks like a small step. I think there's a gap in the.
Exactly,
Okay.
it's not perfectly. Anyhow,
Okay.
this is what we could achieve. And this is a 2-year follow-up. And this 10-year follow-up. In fact, he came just a few months ago. Every year is coming, he will say, I'll take this implant out, but he won't. So that's why he's coming every year. So this is a 10-year follow-up. It's okay, no recurrence, not much pain. But if you see this, definitely there is irregularity in the lateral condyle. So definitely he will develop arthritis. But anyhow, there was no recurrence. Any comments, anybody?
So that's a good salvage of the joint. 10 years follow-up is really good. And there is some lateral compartment arthritis.
Yeah, exactly. Yeah.
I think you can live with that.
Yeah.
That is because I think collapse of the lateral femoral condyle.
Exactly. Yeah.
Arthritis, because of the collapse, I think his knee is going for some slight varus.
Okay, this is the one I did recently, 1 month ago. He's a 36-year-old male, pain left knee, few months, not big swelling. This is how the X-ray looked. And the MRI, okay. And if you see the MRI, they say features are consistent with aneurysmal bone cyst. Nowhere else they say it's a GCT. Okay, they discussed all the features of aneurysmal bone cyst, and they say it's consistent with aneurysmal bone cyst. They didn't bother to say giant cell tumor. Any opinion?
So we'll do a biopsy, sir. Then.
Okay. Yeah, of course. And again, this is CT scan. You can see this multiloculated with fluid level. It's definitely consistent with ABC, but whatever, you need biopsy. And this is what the biopsy says. Giant cell tumor with secondary aneurysmal bone cyst changes. So always biopsies must, even if the radiologists say something else. So biopsy is a must. And what I did curettage, cryo with liquid nitrogen, and I did sandwich technique this time, subchondral bone grafting with autograft and cement filling. And this is what the postoperative X-ray. And you can see the skin necrosis. If you are not careful enough, while using the liquid nitrogen, you get a lot of skin necrosis. In fact, perioperatively, I excised a lot of skin. Even after that, you can see skin necrosis and the sutures under tension. You can see a couple of blisters. Still, the wound is not completely healed. So while using liquid nitrogen, you should be very, very careful. Thermal necrosis of the skin is very common. Right. Thank you.
Thank you, sir. So I have a case present. So you have to stop sharing, sir.
Okay. Where is it? Okay, yeah. Done.
So can you see my screen, sir?
Yes.
So typical primary TKR. The 60-year-old female presenting with bilateral severe arthritis of the knee. Right side there is valgus and mild recurvatum. Both sides knee is stiff. There is no flexion possible. This is a patient standing like a winstep deformity or a tackle deformity. Right side is in valgus, left side is in mild varus. You can see the recurvatum both sides, right side more than left side. You can see the knee flexion. That's all possible. Knee is straight. It's going to reverse direction, nothing forward. This is stress X-rays. The deformity varus valgus is correctable, but this is how she stands. So how do we proceed with this case? Any opinion from the faculty?
Hinged knee is the option.
Yes, sir. But how do we correct the recurvatum and how do we achieve flexion? Any tips? I'll show the introp image also. It's what while painting and draping, it's how the leg went.
Oh God!
This much of recurvatum, is it?
Yes, yes, yes.
Hope you are not injured the vessels.
I got scared seeing this. The sister was holding. I immediately ran and asked one more fellow to put a glove and support the tourniquet.
Oh my God!
It was so scary.
Yeah, this is hinged knee only.
So to gain some length in quadriceps, we always use a quadriceps VY-plasty. So I exposed the joint because patella was adherent to the anterior aspect of the femur. It was huge, so we had to reduce the patella size by removing all the osteophytes and gain the exposure. So we exposed for the quadriceps VY-plasty. The entire rectus was exposed. So we need to decide beforehand whether we are going to do a VY-plasty or a rectus snip.
Yeah, that's what the question.
Once we did do a rectus snip, it's not going to. We cannot do a turn down. So pre-op itself, I decided I will do a VY-plasty. So I exposed, preserve the rectus entirely, and then did a turn down. So the distal femur condyle was huge because the entire weight was taken by the anterior flange of the femoral condyle and the patella. The whole time she was weight bearing on the anterior aspect of the femur. So there's quite a huge bone. Once we do the VY turn down, we are able to flex the knee now. Then I did a minimal distal femoral cut to reduce the amount of recurvatum. I just removed a very minimal amount of bone from the distal femur, only the cartilage. Laterally, I didn't remove any bone and did a conservative tibial cut, and all the cuts were done. And I used augment on the lateral side, 10 mm augment on the lateral side, so that we'll correct bring the joint line down. You can see the 10 mm distal augment on the lateral side, so that we can stretch the posterior capsule a little bit. We use the hinge knee, non-modular tibial component and femoral component with a stem. Then after cementing the final closure, we could bring the knee down to 45 degrees of flexion, and we are able to suture the VY-plasty. Is the post-operative X-ray, and this is at 6 weeks follow-up. Patient is still on rehab, and we are given a hinge knee brace and allowed flexion up to 45. Now she's trying to improve it. Extensor lag is there. It might take some 6 months to improve. And she is going to come back for the other side after 3 months. So quadriceps VY-plasty with a hinge knee is very useful in patients with severe curvatum deformities.
Great case, very difficult.
Why did he come to?
Pardon?
Sir, why did he come to you in the first place? What's wanted? How you convinced her?
Now she became totally immobile, and his daughters stopped taking care of her.
Oh, okay.
She said, "Get your knee." And she came during the COVID time,
Okay.
and she said she will stay back here for 3 months, then only go home. The daughter called me and told, "You keep her there. Send her only when she walks." And I told, more than 10 days, very dangerous to keep her in hospital. She might contract COVID. The second post-op day, she developed 1 or 2 fever.
Oh, okay.
And we didn't know whether it's a COVID or post-operative reaction to surgery. And we took CT, HRCT, and did repeat COVID. Luckily, she was negative.
Sure.
On before discharge, also I did a COVID on 10th day, and then only discharged her home.
Okay.
Was it Zimmer knee?
Yes, Zimmer RHK. Zimmer RHK.
Not sponsored.
Sir?
Her daughter sponsored the surgery.
Yeah. Because she could not manage with her.
Dansagar,
Yes, sir.
opposite side.
Opposite side she'll come, sir. Once this quadriceps strength improves, I'll wait for 6 more weeks and then bring her back.
Okay, is she managing with one knee with the cross deformity in the other side also?
The left knee is stiff, sir. It is straight and 10 degrees of recurvatum. So she's just using the left knee to walk to the restroom.
Okay.
Just managing.
Sir, what about the AVN of patella? You cut the blood supply on both sides.
Yes, sir.
That is a concern. Yeah.
That's a concern, definitely. But once the quadriceps mechanism heals, even if the patient develops AVN, doesn't cause any disability.
They can manage.
Yes.
Could you have managed with a constrained knee?
I don't think it's possible, sir. It is really a massive recurvatum. Very difficult to balance a flexion extension gap. The flexion was too tight. I didn't show those videos. The flexion was extremely tight. I have to release the LCL and MCL to get some flexion gap without going up on the insert size.
No.
The flexion gap was very tight. The extension gap was too loose. So too much to manage with the constraint CCK or LCCK like that. So I had to release the MCL and LCL and get the flexion gap opened up, and then close the extension gap with using a distal femoral augment and a very conservative proximal tibial resection. Proximal tibia I would have removed only 4 or 5 mm. Medial condyle I would have removed only 3 or 4 mm. But I put a 10 mm augment. So I had to do so much to stretch the posterior capsule to length. Pari, you are presenting your case?
No, Danshek.
Okay, not ready. So then now we'll go for some COVID discussion now. Both our presidents wanted to share their experience.
Bala sir. Bala, you back to work or not?
Sorry?
Are you back to work?
Yes, I'm working 1 week.
Okay.
Right. You want my experience?
Yeah.
Yes, sir. Yes.
Okay. Right. Almost 3-4 weeks back, I had a couple of days fever. Saturday, Sunday. In fact, Saturday was fever. I came to hospital only in the afternoon. And Sunday, not bad. In fact, I went home. I met my mother, went a small condolence meeting also. That's second day of my fever. Okay. I don't know how much I spread to others. Anyhow, Monday morning, came to hospital, had a couple of surgeries. Monday evening also, I had low-grade fever. Then only I thought, why I'm having fever for 3 days. So I should check up. So evening, so I couldn't get swab done. So suddenly I went to CT room and did CT. And suddenly I could see a small lesion and the radiologist said it's a Corad 4 suspicious lesion. Okay, so I thought, okay, I'm into this game. And next day, I went to Ramakrishna, had swab done, and evening 4 o'clock, they said, you're positive. Anyhow, but luckily, the third day, low-grade fever, no cough, no difficulty breathing, otherwise mild body ache. So I discussed with a few guys, and everybody said, on the same day, I did the inflammatory markers, ferritin, D-dimer, and all those things. Everything were normal, including CRP, everything were normal. So there is no inflammatory response, no respiratory symptoms. So they said you can be at home. So there is no need for hospital admission. And I consulted a pulmonologist. He said, be at home. Regarding this antiviral, he said, have this favipiravir oral. So I started favipiravir, the 9 tablets the first day, and subsequently 4 tablets every day. So 2 days were all right. That's Tuesday, Wednesday. Thursday, at some point at 11 o'clock, 12 o'clock, I had some tachycardia, unexplained tachycardia. It went up to even 120. That time I really scared, right? There's no point in being at home. And I called Chokalingam, and went to Royal Care. By the time when I reached Royal Care, my cardiac symptoms all settled. There is no tachycardia, everything was all right. And they did all this echo, all this blood investigation, everything were normal. But still I decided it's better to be at the hospital for a few more days. So I stayed there for 3 days, and Royal Care, they didn't give any antiviral. They say there is, if you don't have any respiratory symptom, there is no need for antiviral. And the steroid also, they said, no, we don't give steroid. The complication of steroid is more than the benefits. So I stayed there for 3 days, and for having some vitamins and Clexane. That's the only 2 treatment. Nothing much. After 4 days, I said, the pulmonologist said, you are fine, you can go home. After having all the inflammatory markers again were normal. So after 4 days, that is 9 days after symptoms started, I came home, and I was at home. The favipiravir antiviral, it's very difficult. After 4 days, I could not take it. It's really, the GI disturbance is so horrible. I stopped it. And I had body pain, headache for another 4 or 5 days. That's the only thing. After 5 days, the body pain all settled, headache settled. But I had this fatigueness that was there for almost 2-3 weeks. And nothing much. After that, the inflammatory was again normal. After that, I didn't bother to take CT also. So 2 weeks, I almost completely normal. I took another rest for 3-4 days, and back to work. Now I almost normal. But the only thing is, today one of my teacher come from Dr. Sivaraj called me this morning, and he said, how are you and everything? And he had had a chance to see a TV discussion for cardiologists yesterday, and they all suggested the patient should be on long-term antithrombotic, some sort of antithrombotic, because the complication of thrombosis is there for few months. So I'm not taking, but I'm going to take aspirin at least from today for a few more weeks. That's the thing. I don't know whether I have to take a CT scan to see whether there is any lung damage, but I'm really scared to take a CT scan. I don't want to see. So that's how it's going. So I'm completely better now, but we don't know the long-term problems. Anyhow, fingers are crossed. That's my COVID experience. So
what are the inflammatory markers you did, sir?
Ferritin, D-dimer, sorry, inflammatory markers?
The test you did, sir, yes, you're telling.
That's what, CRP, ferritin, D-dimer, What is that? One more? There is one more.
Interleukin 6. Huh?
Yeah. So everything was normal.
Okay.
I never had a short of breath or hypoxia or cough. So no respiratory symptom at all. So
did you check for hypoxia, Bala?
Yes. I had this finger thing every 5 minutes. I checked.
So what was your temperature? Are you feeling feverish or you had a temperature?
The first 3 days only I had temperature. Only 3 days temperature.
How much was it?
It goes up to 101.
Oh, okay.
101.
Yes,
Sir,
now and then I also feel like feverish, but
Okay.
the temperature, it's normal.
Sir, what was the cause for tachycardia, sir?
I don't know. Maybe fear or the myocarditis induced by a virus. I don't know. That's just a transient for few minutes, settled on its own, didn't take any medicine. That scared me really. Not the COVID, but the tachycardia.
Maybe anxiety,
Maybe, I don't know. Maybe, yeah.
It's good that you didn't have any lung issues, major
Exactly,
issues.
yeah.
Maybe that may be the reason.
No loss of taste.
No, I didn't have loss of taste or loss of smell. The two symptoms were not there at all.
Body ache was it? Yeah,
body ache was there. Body ache was there 10 days.
It wasn't normal. It was completely different, is it?
Completely?
It was different one. Normally when you walk or walk,
at least body ache, backache, headache, even headache, frontal headache. I don't know, frontal headache, morning headache.
You had any loss of taste or smell?
No. Both symptoms were not there for me. Okay. Anyhow. So I almost went near the Sorghum and came back.
They advised the 6 meter walk test. Did you try that?
Yes, I did. Sir. It's okay. And the cardiologist interview yesterday suggested take rest as much as possible. Don't do any exercise. Don't exert your body. Don't exert your heart, because we don't know the long-term efforts of heart. So keep the heart safe. Don't do any exercise at all. Normal walking only. That's what the cardiologist advised.
Retrospectively, where do you think that you got this virus?
Maybe from the patients.
Sundar.
Where else?
சீக்கிரட்டான கேள்வி எல்லாம் ஓபனா கேட்க கூடாதுங்க.
It's not HIV, man. Sundar, it's not HIV. It is COVID.
இல்ல கோவிட் பேஷண்ட் ஏதோ ஆபரேட் பண்ணீங்களான்னு கேக்குறாங்க சார்.
If COVID patients operate பண்ணல, we had at least 4-5 patients in the hospital, but we didn't operate. So once we diagnosed COVID, we sent all those back home, but we didn't operate. But of course, I spoke to the patient. Even I touched that patient.
ஆபரேட் பண்ற பேஷண்ட்ஸோட ஓபில பேஷண்ட்ஸ் ஏதாவது மாஸ்க் போடாம இருந்து அந்த மாதிரி தானே சார் வந்திருக்கும் மோஸ்ட்லி.
எப்படின்னு தெரியல, மாஸ்க் போட்டிருந்தேன். I didn't wear N95, to be honest. I just wear the ordinary surgical mask. I didn't like.
Mask photo, you don't give the disease to others. That's the main, other than getting from others.
Patient கரெக்ட்டா போட்டுறணும்ல மூக்கு மேல.
Protect others.
போட முடியறாங்கல.
Anyhow, be safe. Better to be preventive. Don't get.
Sure.
TMS.
My symptoms started on a Sunday. I had a normal Sunday at home, and in the night time I developed a body ache. That's the only thing, generalized body ache. In the morning I was not okay, and the next day is Monday. I had a busy outpatient clinic. I was looking at almost 30 patients on that day, and we had 3 surgeries to be done. I did the first surgery, a wrist surgery, that was okay. Then I thought the next Tuesday I booked a resort in Valparai for 3 days. So I thought, suppose if I have a COVID and if I get into Valparai, then I may not be able to come back. Better check before going to Valparai. That's why I gave the test at 11 o'clock on Monday. Then preparing for the second case to operate, almost scrubbed, everything ready. Then the microbiologist called, "Sir, you are COVID positive." Then immediately I called boss, please come and take over this case because I cannot operate. At the time I had generalized body ache, no sore throat or anything. Then the same night I got admitted. When I got admitted, I developed sore throat, no fever, no tachycardia, no saturation loss, but the lungs CT shows 5% pneumonic patch in the posterior aspect. So I was given remdesivir immediately, and also steroid Dexa 6 milligram IV, 5 days. At the end of 5 days, 6 days, CT was repeated, which showed the same thing. There was no progress of pneumonia. Apart from these two symptoms, on one day I had 99 degrees of temperature. That's all, no fever at all. But I had loss of taste and smell, which recovered in a week's time. With this treatment, and I'm taking tapering dose of steroids now. I feel much better. All the smell and the taste has come back. Body pain completely disappeared even after the third day of this admission. I have like a regular viral illness, some kind of mild tiredness is there, but I feel I'm all right to work now, but I'm going to take for a week, then probably next Monday I will join. So overall, the course seems to be mild for me. But all these complications mentioned, long-term complications, myocardial injury, lung injury, fibrosis, all these things, we don't know. It just comes, you'll take it, that's all.
So what was the dose of steroids you had, sir? High dose or?
6 milligram IV dexamethasone.
Okay. How long?
6 days.
Okay. Remdesivir for 5 days, sir.
Then tapering dose of prednisolone tablets.
Okay.
That is 16 milligram 3 days, 8 milligram 3 days, 4 milligram 3 days.
Okay.
It is very controversial. There is no consensus in the treatment. Everybody got their own protocol. So
yeah, remdesivir is of no use now. They say
exactly.
absolutely no use.
No, they're saying it does not reduce the mortality rate, but reduces the course of the illness. That's what they say.
That's what I personally feel. And also I had a Clexane injection.
Yeah.
How was your inflammatory parameters, sir?
Initially, day of admission, it was normal. And day 5, the CRP was initially 2, then it went to 11. Then IL-6 went to from 5 to 50. After that, it declined. Not much.
TMS, so they're starting you on any anticoagulation?
Yeah, they put me on this Clexane initially, then this oral anticoagulation for 14 days, they say.
Xarelto, sir, what you're taking?
Sorry?
What drug you're taking? Oral?
Apixaban,
okay.
Apixaban,
yeah. David Rajan.
Sir, good evening.
Sir, good evening, sir.
I'm glad both of you recovered uneventfully.
Thank you, sir. Thank you.
Now, just one question about the antiviral. And you had, Bala, you had antiviral and Thirumalai did not have.
No, I had.
No,
sir, I had oral. I had oral antiviral for 5 days and I stopped.
No, there's some literature
sir,
indicating that antiviral leads to fibrosis of the lung.
Oh, God.
No, I'm not trying to frighten you. No, just I mean, how true it is, and could you have avoided having the remdesivir?
WHO's today's it's come out report which says remdesivir is of no use. It doesn't decrease the duration of illness, nothing.
You know, is it harmful?
Harmful, don't know, but it's of no use. Why?
Maybe steroid would reduce the fibrosis, sir. Adding steroid with that.
Yeah, our nephrologist, Dr. Pathak, was repeatedly calling me, please do not stop steroids. Please do not stop steroids. That was the only message he was telling me from the beginning.
In Royal Care, they are very much against steroid. They say the complication of steroid is more than benefits. Okay. So it's all very much.
Let us be the guinea pigs for COS and let us tell what's happening to us.
Yeah, I'm glad both of you recovered so very well. Thank you very much for your comments and telling us what to do, how you did. However, we're sorry we missed Sundar.
Sundar, yeah.
And may his soul rest in peace. Thank you.
Thank you.
So only both of you are immunized now.
We don't know. And
For
we
the
don't know
time
how
being.
long, if at all.
Short term.
Short terms.
Now they are advising flu vaccine. Is anybody is having it? Bala?
No, flu won't come. All of you are wearing masks. No, flu is not going to come. The only thing which is going to come is if you have fever, it's definitely COVID.
Okay.
Ordinary flu won't come. Everybody is wearing masks. So.
ரெண்டு ஹாஸ்பிட்டலே ட்ரீட்மெண்ட் வேற. இப்ப எங்களுக்குலாம் வந்து எங்க போறோம்னு தெரியல. இப்ப ராயல் கேரா, இப்ப கேஎம்சிஹெச்சா?
ஸ்டீராய்டு வேணா இங்க கேஎம்சிஹெச், ஸ்டீராய்டு வேண்டானா
No, the numbers in the past few days have drastically come down.
Come down, yes.
Yeah. In our hospital, about 15 beds are vacant. Till then, they were the waiting list queuing up.
Vinod, hospital la கூப்பிடுறாங்க, ஏதா கேஸ் இருந்தா அனுப்பி சொல்லு.
Correct. 15 beds vacant.
That's a good news.
No, but let me tell you one thing very important to share. This Dolly, her friend, somebody is working as manager in micro lab. 800 cases were done, but they're saying 350 loiklana need to cancel your license.
That's true.
But however, please note that the labs have been warned.
Yeah.
Okay.
Very, very clear about it. Labs have been warned.
Okay.
Not to disclose the.
So don't take life easy.
Exactly.
Thanks both of you.
More positive result. Again, they are warned, I think. They'll be scrutinized.
Bala?
Hi.
Antibody test பண்ணீங்களா அதுக்கு அப்புறம்?
இன்னும் பண்ணணும். TMS நீங்க பண்ணீங்களா?
TMS பண்ணீங்களா?
4th week பண்ணனும்.
Okay. Right.
Antibody test பண்றாங்களா?
பண்றாங்க.
மைக்ரோ பண்றாங்க.
நம்ம ஹாஸ்பிடல்லயும் பண்றாங்க. ONT சார்?
Yeah.
அப்படிங்களா?
நம்ம ஹாஸ்பிடல்ல பண்றாங்க. Before COVID I did. I was negative. No antibodies in my blood.
Bala also did.
நானும் பண்ணி பார்த்தேன். ஒரு நப்பாசி இருந்துச்சு. இல்ல.
Reassuring.
ஏசிம்ப்டமேட்டிக்கா வந்திருக்க மாட்டேன்.
சார் இப்போ என்ன மாஸ்க் போடுறீங்க? சர்ஜிக்கல் மாஸ்கா என்ன?
சர்ஜிக்கல் மாஸ்க் ஒரு வைசர் வேணா போட்டுக்கிறேன். இப்போ கிளாஸ் வைசர். இந்த மாதிரி வைசர் ஒன்னு போட்டுக்கிறேன்.
We're saying high chance of sir,
high chance of useful இருக்கா? Do you think it's useful? The visor.
வைசர் யூஸ்ஃபுல் தாங்க.
வைசர் ரெண்டு காரணம் சொல்றாங்க சார். ஒன்னு வந்து யாராவது தும்முனா நம்ம மேல அடிக்காது.
In our hospital, he said
it protects the conjunctiva of the eyes from exposure.
இல்ல அப்புறம் இன்னொன்னு வந்து if you have visor, you don't put your hand and try to pull the mask down. That reduces the frequency. அது ஒன்னு சொல்றாங்க.
Yeah, second line of defense.
Message going around that people develop pulmonary hypertension with using all this N95 plus masks. Is that of any information of any importance? Some of the physicians are mentioning people are reported to develop pulmonary hypertension with use of this mask.
Is it a published thing or just a word of mouth?
It's word of mouth. The physicians were saying they have read some reports.
I don't think N95 could produce pulmonary hypertension.
அந்த அளவுக்கு இல்ல.
They're not so good.
But you have to continue protection, sir. Chance of reinfection also is there.
Yes.
We all have to be very careful. Still, we don't know where we are going to because
we will be doubly careful because we gone through this trauma.
Not take any risks.
It's depressing psychologically.
நிறைய வந்து இந்த மாதிரி வெட்டிங்ல கண்டோலன்சஸ் இதுல தான வருதுன்னு சொல்றாங்க போகும்போது.
ஆமா. 100%.
The moment when you are positive, the psychological trauma, or even if you are being tested and waiting for the results.
My problem is my wife also got infected in the same time, so we were in the same room. And both our children are in US. So we never know what's going to happen. So,
True.
so that was a really shocking time.
See, it's very unpredictable virus. The first 3 days of my high fever at home, my wife was with me only, shared same bed, even blanket, but somehow she didn't have. So the virus is very unpredictable.
Did you check her?
Yes, we did.
But anytime it brought you fear of death or anything like that?
Yes. It's always. Especially when you hear somebody says there was a death 40, 50-year-old man, you really get scared. Right?
Okay,
sir.
So hope we don't want any experience from others. Be safe. Not a good experience.
Sir, would you like to share a few words about Dr. Sundar or somebody?
Who knows?
DVR is there.
DVR kara?
Yeah, I wish you told me earlier. But however, I should not say I cannot share. Sundar, I knew for a long time when he was assistant here, and then out of the PG time, after coming here, Coimbatore, and only look for his company. It's really nice, and he is a very jovial person, very light-hearted, very affectionate, and he always has something nice to tell about you, and he takes life very easy. The common response he says for anything and everything is, so lately, apparently, even that's what he said about even his infection. From what I observed and what I didn't want to say here was that you both, Bala and Tirmalai, went for treatment quite early, and apparently he didn't. Probably he could have been with us had he gone for treatment earlier. However, anyway, it's all not in our hands. It's God's will. He was, as I read and as I gather, he was very popular among his students. And he was very jovial in his rough voice and very authoritative. And he was a very good friend, really very good friend. And Vinod and myself had the opportunity of having his hospitality in Dubai when he invited us for a meeting. And we both went and gave a lecture. And he took care of us so well. And he doesn't leave anything unturned. He's a good host. He's a good person overall. He's a good orthopedic surgeon and a good colleague. And later on, I went to Muscat, not Muscat.
Dubai.
Dubai. Qatar. We went to Qatar. On the way back also, we spent some time with him. And he was really nice. After coming here also, we've been in touch. So one thing I really feel sorry, and apparently he told a lot of people that he had not invited a lot of us, his good friends, to his house for a party or whatever. And that is unfulfilled the dream of him. And I think I shall not go any further down. And we are very unfortunate, and it's so sad that we lost him at his age. He could have been there for much longer. And Dhanavani, myself, and all look for him for his very. If and when I come for the Coimbatore Orthopedic Society meeting, good company, very good company, very jovial, lively. And Sundar, we miss you for your friendship, for your sense of humor, for good habits, and your good heart. And this is very rare to come nowadays. And we're really going to miss you. And I don't know what I'm going to do next time when I come to COS meeting. Anyway, thanks for asking me to talk about him. We are really going to miss him. We the senior guys, not your age, your Bala, Vinod and Thirumalai, but the senior age. We're really going to miss him. Thank you for asking me. Thank you for giving me this opportunity. Thank you.
Thank you, sir.
Thank you.
Just I want to say a few words about Sundaravadanam. I knew him only for the past 4 years, too, as a gym partner. We have a gym next door to our house. I used to see him every day in the gym. He was the first person to arrive. 5:45 before the gym opens, he was the first person with his wife. And he's a very fit man. He's a very fit man, and he does at least a couple of hours. He leaves only around 7:45 or 8. We used to talk a lot about dogs. We have 4 Alsatians, and every day he looks at the dogs, and after a recommendation, he bought an Alsatian from Bangalore. And we used to share a lot of experience about Manasarovar trip. I went to Manasarovar. Before that, he went to Manasarovar. And he's a very pleasant chap. And I was happy that I managed to get to know him. It's a sad thing now to think about not seeing him before Corona. And now during Corona, the gym was closed and I never had a chance to meet again. I felt very bad. I couldn't see him again, and sudden loss. And it's a very short meeting, in my life. So just 4 years. Before that, I didn't know him. He's such a pleasant man, very pleasant, and talk a lot about life experience. We really miss him. May his soul rest in peace. We pray for his eternal peace. Thank you for this opportunity to share the thoughts. Thank you.
Anybody else want to share something, sir? So I would like to share my experience with him. So I was a student in Coimbatore Medical College, and the first year he was our anatomy tutor, and subsequently moved to the orthopedic department, and he was our teacher in anatomy as well, orthopedics as well. And he was very affectionate to all our batchmates, and Pari also shared the same experience. And we went with him for college tours and all. And almost 10 or 12 years back, even when I was a junior consultant, I operated his brother-in-law. I did a knee replacement. As a student, he was affectionate to me, and he had a lot of confidence in me as a surgeon as well. And every time we meet in the COS or elsewhere, he used to be very affectionate and kind, and sharing some good advice to me. So I pray for his soul to rest in peace. And I remember him with a lot of respect and love. Thank you. So, can we conclude the meeting, sir?
Yeah, of course.
Thank you, sir. Bala sir, can you?
Yeah. Well, we had an excellent guest lecture by Singer Vadivel today. I hope all enjoyed. And I thank you all for participating in this webinar. Also thank Dr. TVS sir, ONP sir for their memories about the past Dr. Sundaravadanam. So once again, thank you all and good night.
Thank you, sir. Good night, everyone.